right, so again, good afternoon, everyone. My name is Arne Burns. I am the Health Education and Training Specialist here at Illinois Public Health Association. And thank you for joining us today for our Fed Talk series. Fed Talk series, our public health education series, are just a series of semi-monthly webinars that we offer with a wide variety of public health topics. So today we're going to be talking about exploring novel tools to address the fentanyl crisis. And our guest speaker today is Dr. Desiree Crevecoeur McPhail. If you are joining us today for continuing education credits, just know that attendance will be tracked via Zoom. If you would like to receive a regular certificate of attendance, or if you're here to earn CHES credits, I will be placing an evaluation form link in the chat box at the conclusion of the session. And then the deadline to submit that evaluation to earn credits will be July 25th. So like about a week out from today. And then just general housekeeping, just make sure to have yourself muted. We do have a fairly full house today. Questions will be answered intermittently throughout the presentation. So for any questions that you have, please feel free to put them in the chat and I will share that with our guest speaker. And now that I have got us all situated, I'm going to go ahead and turn this over to Dr. McPhail.
Thank you very much. Hello, everyone. Thank you for taking the time to join us today. I am Dr. Desiree Crevecoeur McPhail, and I am here to talk to you about exploring novel tools to address the fentanyl crisis. So as we get started, just a little bit of information about me. I am the medical director of Velocity Bio Group. I also work with Hikma Community Health, which is a manufacturer that produces numerous forms of naloxone. I spent, it was probably now more than 25 years in substance use disorder treatment, primarily as a researcher, but I also worked with federally qualified health centers or FQHCs. I worked with nonprofit treatment centers, et cetera. And a lot of that research or a lot of that work focused on improving treatment outcomes. So for example, I and my team focused on changing the assessment protocol to make it easier to get people into treatment and to get people into treatment faster. We worked with treatment programs to improve their use of evidence-based practices and medications. We also help with substance use disorder treatment programs to help them better coordinate care with mental health treatment or with physical health treatment, just to make that whole process easier on the patient. And I have over 24 publications in and around the field of substance use disorder. So my disclosures, again, this is touching on what I just mentioned. I am the medical scientific advisor and senior director of advocacy for Hikma Community Health. And again, Hikma Pharmaceuticals manufactures several forms of naloxone, including the 8 milligram intranasal naloxone medication, Cloxado. I'm also the SUD Medical Affairs and Advocacy person for Velocity Bio Group. And Velocity Bio Group is contracted by Hikma for marketing and other work. So that is me. So a couple of notes about the presentation today. The sources of the information on the slides are included in either footnotes or at the notes section at the end of the slide deck. Do keep in mind that there is about an 18 to 24-month lag on data. So a lot of the most recent data we're going to see is probably 2021, and there'll be some 2022 data as well. Some of these slides are not mine. Some of the slides were taken by a presentation from Dr. Nora Volkov, who is the director of the National Institutes of Drug Abuse. And she made this presentation in April of this year at the American College of Medical Toxicology at their annual conference. So now that we have that out of the way, here are the goals for today. We are going to talk about the current overdose crisis and how it's different from previous crises we've worked through. We are going to talk about the considerations when addressing opioid overdose. More specifically, we're going to talk about the opiate naive. We're going to talk about hypoxia. And then finally, we're going to talk about the various medications that are currently available to address opioids, opioid use, and more specifically, opioid overdose. First up, the current overdose crisis. So in this section, we're going to talk again about the current crisis and how it's different from previous crises. So I'm going to go over some of the current data. We'll talk a bit about fentanyl and how it differs from other opioids. We're also going to talk about something that has been referred to as the fourth wave of the overdose crisis. And from all that information, we'll be able to discuss how the current overdose crisis is very different from previous overdose crises, overdose events we've experienced as a country. So first up, and I'm sure for a lot of you, this data is not new. We are looking at the drivers of overdose deaths. And we know for the last 15 years or so, we've been seeing a dramatic increase in probably actually closer to like the last 20, 25 years. We've been seeing a dramatic increase in opioid overdose deaths. Now, for a long time, that was driven by the use of, let's say, prescribed opioids and then later by heroin. But starting in the mid-2010s, we saw this rather dramatic uptick in opioid overdose deaths linked to other synthetic opioids, more specifically non-pharmaceutical fentanyl. So we're talking about illicit fentanyl, not the fentanyl that you might be prescribed or the fentanyl that might be administered in an ER situation or more specifically during a surgical procedure. This non-pharmaceutical fentanyl has varying degrees of potency, but generally speaking today, we'll talk about fentanyl overall as being about 50 times more potent than heroin and 100 times more potent than morphine. Now, the good news is we might be seeing a bit of a leveling off in opioid overdose deaths. That is very preliminary. So please don't quote me and say Dr. Crevecoeur McPhail said that there was a leveling off or a decrease. I say we might be seeing that. Again, it takes some time, several months, even a year or more to get all the data in from the various states and jurisdictions across the country. But this is basically what it's looking like. Now, the other thing we have to keep in mind, and I'll talk more about this over the course of the presentation, is the communities that are being impacted by fentanyl and opioids are also shifting. That is changing across the country. For example, in one major city in a rather large state in the country, and I won't say what state it is, in the previous year, 43% of the opioid overdoses were in opioid using communities, and like 57% of the overdoses were in stimulant using communities. And we're starting to see more and more of that across the country, where individuals who use opioids are familiar with naloxone. They know where to go to get naloxone. They've administered naloxone previously. So we're starting to see deaths start to level off in some parts of the country in that community. Unfortunately, we're not seeing dramatic decreases because that decrease in opioid users is being matched by an increase in opioid-related deaths in stimulant users. And we'll talk more about why that might be in a few minutes. So as we can see from this chart, which also came from the presentation by Dr. Nora Volkov, we see that looking from 2022 to 2023, the changes in overdose deaths. So heroin's decreased, natural and semi-synthetic. This is basically, for the most part, prescribed opioids. That has decreased. Methadone, which is another type of opioid, has decreased. Synthetic opioids have increased. But again, we're seeing increases in deaths in stimulant users. And as we'll see from data today, a lot of these stimulant user deaths also have fentanyl in their toxicology reports. Now, all of this information is national-based data, but if we look specifically at Illinois, we'll see that there actually, from 2021 to 2022, there was a bit of an increase in opioid overdose deaths, basically going from 3013 in 2021 to 3261 in 2022. Fentanyl deaths also increased, but similar to the rest of the country, deaths related to other opioids decreased. And unfortunately, cocaine fatalities increased by 16.3%. And as I mentioned earlier, the vast majority of these overdose deaths also included opioids, over 80%. And we see in this chart on the right-hand side of the slide, the percent change in what we're seeing in overdose deaths. So again, any opioids increase, cocaine increase. But again, we have to keep in mind, this is not just cocaine. This is people who are using cocaine and opioids, or people who are using cocaine thinking that they're using cocaine, but unfortunately that cocaine has been laced with fentanyl. So as we see in the chart or table 3 on the left-hand side of the slide, we see that number one, the vast majority of overdoses involved in opioid, 92% for Illinois. And in 2/3 of those deaths, some other substance was included. So either cocaine, multiple substances, a psychostimulant such as methamphetamine, a benzodiazepine, or alcohol. And alcohol and benzodiazepines are also central nervous system depressants. So whenever you mix multiple CNS depressants together, you're going to get this unfortunately deadly cocktail of respiratory depression and death. On the right-hand side of the slide, we're also seeing how this increase in overdoses is impacting various communities in a very disproportionate way. So although we see that non-Hispanic white individuals had the highest number of overdose deaths, when we control it by, let's say, population, it's actually non-Hispanic Black individuals who are dying at a much higher rate, 73.9 per 100,000 individuals. So this basically shows a significant disparity in the population that's actually being impacted by these opioids, with Black African-American individuals dying at 3.5 times the rate, or 3.5 times more likely to die when compared to non-Hispanic white individuals. And I didn't include it in this slide deck, but in the report that I took this information from, which is cited here, there is another table that shows that when you break that information down by age, this disparity of African Americans being 3.5 times more likely to die is even greater depending on what age group you look at. So in other words, this is kind of an average. If you look at even older African Americans, they are even much more likely to die of an overdose in comparison to other demographic groups. And that, I think, is important to keep in mind, because depending on where you live in the country, depending on what type of media you consume, when you think about someone who uses opioids, you might have a particular image that comes to mind. And that image might not be of African Americans. It might not be of Hispanic or Latinx individuals. Also, those communities who primarily use stimulants may think to themselves, I don't need to have naloxone because I don't use opioids. I think it's incredibly important to make sure that whatever community we're working with, if they're using illicit substances, be that opioids, be that cocaine, methamphetamine, they're ordering pills online and using those medications illicitly, whatever the case may be, everyone needs to have naloxone, because right now it's very rare to find any type of illicit substance out of, let's say, marijuana and alcohol, if you will, that is not tainted with fentanyl. Are all the substances, is every single sample tainted with fentanyl? No, but depending on the data you look at, it's upwards of 80% of the samples that are seized by DEA are now tainted with fentanyl. So how is fentanyl different from other opioids? And we talked a little bit about this earlier. So again, fentanyl is much more potent than any of the other opioids we are used to dealing with. Again, 50 times more potent than heroin, 100 times more potent than morphine. But we also have to keep in mind that in addition to the potency, the pharmacology, or let's say the chemistry, the way that fentanyl works in the body, the way that it operates in the brain is much different than these other opioids. So for example, when someone injects heroin, the body basically converts heroin to morphine. And although heroin is, let's say, twice the potency of morphine, the body still looks at it as if it were morphine. And morphine is not very lipophilic, at least not in comparison to fentanyl. And lipophilicity, or a substance being lipophilic, just basically means it crosses in and out of the bloodstream very easily. And that means it crosses the blood-brain barrier very easily. So when we compare even something as potentially deadly as heroin, if we compare it to fentanyl, fentanyl is much more deadly. We have the increased potency, the fact that it can get into and act on the brain much faster than any of the other opioids we've been dealing with for the past 20, 30, 40 years or more. So it's kind of a combination of increased potency, the fact that it's fast acting is one of the drivers of the increase in overdose deaths we've been seeing. A fentanyl overdose can happen in a few seconds to a few minutes. And that kind of truncated timeline we have to respond to the individual who's experiencing the overdose is, again, one of the drivers of the overdose deaths, and something that we'll have to keep in mind as we go through the rest of this presentation. Also remember that we have a significant proportion of the population who is arguably opiate naive, or at least not, let's say, physically dependent on opioids, and they are being exposed to deadly amounts of fentanyl as well. So why does this matter? Why does the pharmacology of fentanyl matter? Well, for a couple of reasons. Oh, excuse me. Number one, we've heard from the CDC and NIDA, multiple warnings that came out over the last, let's say, 5-10 years or so, stating that because we're seeing more and more fentanyl in the drug supply, and we're seeing it in counterfeit pills, we're seeing people who don't use opioids being exposed, we may need more naloxone in order to reverse these opioid overdoses, multiple doses of naloxone, higher doses of naloxone, et cetera. I was actually working or did a similar presentation for an organization yesterday, and one of the gentlemen on the call told me that there have been several times where he's administered naloxone to the person, they seem fine, they're breathing again, and then a few minutes later, they're unconscious again. In other words, they've slipped back into their overdose. And that, unfortunately, is not uncommon with these opioids. One of the things to keep in mind is that most opioids will outlast a dose of naloxone, depending on the dose and depending on the formulation. It's one of the reasons why if you are admitted to a hospital following an opioid overdose, they may just attach you to a continuous naloxone drip because they know how frequently that can happen. Another reason why this matters, and I talked a little bit about this earlier, is we are starting to see something that has been referred to as the fourth wave of the overdose crisis. And this fourth wave of the overdose crisis specifically has to do with fentanyl getting into the stimulant drug supply. So previously, I should mention, this is not the first, let's say, opioid overdose crisis we've had. There have been several times throughout our country's history where we had a significant increase in opioid overdose deaths. It happened in the 60s, early 70s. Then we shifted to methamphetamine. Then we shifted into cocaine in the 80s, early 90s. Then we shifted back to methamphetamine. And now, again, opioids are taking center stage. What is unique about what's going on right now is we've never had the sort of pervasiveness of an opioid getting into other drug supplies. We've never had it where you order cocaine or you get cocaine from your dealer and you have to worry, does this cocaine have fentanyl in it? That's not to say this is the first time people have used stimulants with opioids. That's not the case. But usually when that happens, you're doing that mixing yourself because you purposely want that, or you ask that of your dealer. You want something that has cocaine and heroin in it or something like that. Now we have a significant proportion of people, again, who use stimulants and are being exposed to fentanyl or opioids without their knowledge. And this mixture of opioids and stimulants can be especially dangerous. So just to kind of sum up this first part of the presentation, again, when we look at the current crisis in comparison to our history of dealing with overdose deaths, we have this increased potency and lipophilicity of fentanyl. This results in a higher number of overdoses than we've ever seen before in our country's history. We have either the purposeful adulteration of various substances or the accidental contamination of other drugs, stimulants, pills, etc., which means other communities, groups of people who, again, may be opiate naive, communities of people who don't know they should have naloxone, even if they're just using cocaine or methamphetamine, they're being exposed to these high potency opioids. Again, this fourth wave. We have the inclusion of other contaminants, which I haven't even talked about, like xylazine, which can exacerbate the health consequences of using opioids. And as stated previously effective doses of naloxone may not be as effective because we're dealing with different communities, because we're dealing with different opioids, and multiple repeated higher doses of naloxone are being suggested by various groups. So I'm going to pause here and see if there are any questions. Any questions about any of the information I've shared so far?
If anyone has questions, please feel free to put them in the chat and I can relay them. Or if you're at a space where you can unmute your microphone and ask, that's perfectly fine as well.
Well, if there are no questions, I will continue on. There'll be time for other questions towards the end. So maybe you're formulating a question or it hasn't quite come to you yet. Oh, I do see something popped up in the chat.
Yep, I just saw one. What is the point of origin of fentanyl?
That is a good question. Now, fentanyl itself is a medication that is used in hospital settings. It's primarily used in a couple of different formulations or a couple of different ways. Number one, it's used during surgeries or surgical procedures. And I've spoken to an anesthesiologist. One of the reasons why we use fentanyl is because it is so predictable. So you give a particular dose, you know how long that dose is going to last. And if you need to reverse it with naloxone, you know exactly how much naloxone you need, for example. And it was also used in like patches for people who have cancer and that sort of thing. So fentanyl itself has been around for decades, and we used it primarily as a medical resource, if you will. Now, illicitly manufactured fentanyl, that is a relatively recent development. And why someone decided to kind of cook up fentanyl in some sort of clandestine laboratory or what have you and add it to the drug supply. Good question. I think it's tied into cost. You can get the precursor chemicals from China very relatively inexpensively. I don't know how easy it is to get those chemicals anymore, but I know at the beginning of the crisis, at least, it was relatively easy. And we also know that fentanyl is much cheaper to produce than heroin or some of the other opioids. And I think you could make the argument that it might have initially been added to drugs in order to increase the potency while also decreasing the manufacturing costs. And at some point, the system as it is basically just shifted primarily or exclusively to fentanyl. Why it's ended up in the stimulant supply, again, that's could be a number of reasons. Because fentanyl is so addictive, that might have been the reason why it was initially added, or and we're thinking about, let's say, your typical drug dealer or what have you. It's not like they operate in a clean room where, in other words, there might have been at least initially some accidental contamination that might have happened, and then that also took off. So where the illicit supply came from, there are a few different theories around that. But fentanyl itself as a medication, as a painkiller or a pain reliever that's been used in the medical field has been around for decades. And I see your question, Ava, what is the motivation to mix fatal levels of fentanyl into other drugs? I don't think the motivation is to mix fatal amounts of fentanyl into the other drugs. I think the motivation was to put fentanyl into other drugs in order to increase the likelihood of the person becoming more addictive. I think that was the initial goal. I don't think necessarily that the drug dealers or whoever are thinking like, I'm going to kill off my customers by putting this extra fentanyl in there. I think they put it in there to get their clientele, if you will, to experience the drug that they gave to them as being qualitatively different, a different kind of high, maybe a more pleasurable high, certainly a more addictive high. And I think that's where it started off. But I think a lot of people don't understand, number one, how potent fentanyl is and how dangerous it is to give to someone who is opiate naive. Number one. Number two, from various toxicology reports, DEA analyses, we know that illicit fentanyl, the potency ranges dramatically. So can be 50 times as potent as heroin, but I've also seen data on samples that were 270 times as potent as morphine. So the potency itself can vary depending on the supply. So I also see another question, how does fentanyl impact the liver? I think the way we look at it, you can look at it the way opioids impact the liver in general. So there's going to be some impact around there. I think the major issue when we talk about the liver is the fact that because the liver, it acts as the filtration process for the body, that any sort of additional contaminants that's in the supply is significantly going to impact the liver. Again, where these illicit medications, I shouldn't say medications, where these illicit drugs are being created, they're not necessarily like clean rooms where everything is sanitary and controlled and that sort of thing. So we're going to see not just the potency of the fentanyl in the variant potency that it has, but also any other contaminants like xylazine or anything else that might end up in the drug supply. All right, I see a couple of other questions. Let's see. Yeah, so I see the question, when you say previously effective doses of naloxone may not be as effective, are we determining effectiveness by restored breathing or restored consciousness? That's a great question. Because of the addition of other contaminants like xylazine, and if you're not familiar, xylazine is a large mammal tranquilizer. It's used in veterinary medicine. And when I say large mammal, I don't mean like large dogs. I mean like horses and deer. And xylazine is not approved for use in human beings, but it is a tranquilizer. So it causes unconsciousness or lack of consciousness in people. So previously we looked to the person regaining consciousness, because by regaining consciousness, we know that their breathing has returned to normal. But for the last several years, we no longer look to see if the person has regained consciousness. We look to see has their breathing returned to normal, whether or not they regain consciousness. And one of the things we're seeing from the community, and I have a couple of slides on that we'll get to in a few moments, is that people are reporting that previously they were able to give, let's say, a 4 milligram dose of the nasal spray, and that revives the person. Now it's taking 2, 3, 4, multiple doses, not necessarily all given at the same time. Again, sometimes people will be given a dose, they're okay, and then they fall back into their overdose. So then you have to give them another dose. And sometimes it's given a dose, you wait 2 or 3 minutes, the person's breathing still hasn't returned to normal. You give them another dose, still not to return to normal. You give them a third dose, that sort of process. So great question. It's not necessarily restoring a restoration of consciousness. It is whether or not their breathing has returned to normal. And again, keep in mind that nasal formulations of naloxone are going to work differently than formulations of naloxone that you inject. All righty, and I see one comment from Deanna. Excellent. Okay, good. All right, so let's move on. In this next section, we're going to discuss other considerations when addressing opioid overdoses. So we're going to talk a lot more about the opiate naive, and we're going to talk about a topic that I feel like doesn't get enough attention, and that is hypoxia. So as we already talked about, or as I've already discussed, we're seeing increases in opioid overdose deaths in communities of people who may be opiate naive, who primarily use other substances. So for example, the CDC found that in 2022 of the cocaine involved deaths, over 70% involve synthetic opioids. Of the benzodiazepine involved deaths, almost 2/3 involve synthetic opioids. And when we look at deaths related to other stimulants, such as, let's say, methamphetamine, half of those deaths involve synthetic opioids. And I think more recent data shows that these numbers have continued to increase. Like we talked about in Illinois data, and I've just forgotten the number, but I want to say it's like over 80% of the cocaine involved deaths also had an opioid tied into it. And probably some of the more heartbreaking stories we're seeing are young people, college students, high school students who order counterfeit pills online, even pills that shouldn't contain opioids like Adderall, and those individuals experiencing an overdose and sometimes dying of an opioid overdose because those pills actually have a deadly amount of fentanyl in them. Both Ohio State Poison Center and Ohio State University Office of Student Life released warnings following such circumstances. And I think at Ohio State University, there were several students who died as a result of ordering these counterfeit pills online. So again, we have to keep in mind that the landscape has changed. Previously, young people, even older people who are experimenting, they do something every so often, they get some cocaine to celebrate, or they only use drugs when they're with their friends, or whatever the case may be. There is no longer any sort of, let's say, safe amount of experimentation just because fentanyl has made it into the drug supply. And then when we look at overdoses by age group, primarily, well, number one, from 2020 to 2021, we saw increases. But primarily what we're seeing are people in the middle age bracket, but that does mean like younger people are immune, or even let's say college, early adult years are immune, or even older populations. So what we're seeing in these opioid overdose deaths is every single age group, every single community being impacted. And again, if we look at overdose rates by race, ethnicity, different groups are being impacted differently. Again, if we look at the United States, we see a bit of a leveling off, some leveling off or reductions in some other communities, but dramatic increases in yet other communities. And again, I think it's important for us to keep in mind that when we think of opioid overdoses, it is no longer just the person who uses opioids that is in danger. It's anyone who uses any sort of illicit substance. They are in danger of a fatal fentanyl overdose. So it's important to keep in mind that, yes, we want to make sure that the individuals who use opioids have naloxone, they have a dose that is appropriate for them. We'll talk a little bit about precipitated withdrawal in a few moments, but also keep in mind that, again, across the country, that proportion of who's overdosing, the stimulant users are increasing dramatically and the opioid users are decreasing. So if we look at some data looking at the use of the 4 milligram naloxone nasal spray in the community, we'll start to see some patterns. So number one, we have a study published by Vishen and colleagues in 2018, and this is data that was collected in 2016 and looked at a sample of about 250 reversal attempts. And what we know from this 2016 survey was that in 34% of the cases, 2 or more doses of the 4 milligram naloxone nasal spray were administered in order to reverse the opioid overdose. And if we think back to the earlier slide, we know that 2015, 2016 was right when we started to see that rather dramatic uptick in overdose deaths related to illicitly manufactured fentanyl. Now, also on this slide is information on adverse events, more specifically related around withdrawal and that sort of thing. And what we see in the table is that from this sample of data, a good proportion of people received 1 dose of 4 milligrams, but there's also a good number of people who received 2 doses or 8 milligrams. Some received 3 doses, some received some unknown number of doses. And when we look at the adverse events across, let's say, 4 to 8 milligrams of naloxone administered intranasally, we don't see any drastic or dramatic increases, and there were no unexpected or life-threatening events reported regardless of the dosage. Now, I think what's also interesting about this sample is that when we look at the adverse events from 2016, where we were primarily still dealing with heroin overdoses and fentanyl had just started taking off, over half of the sample reported no adverse events, including withdrawal symptoms. That changes with more recent data. So if we compare it, for example, to a study that was published in 2022, looking at data collected at the very beginning of 2021, in this sample, in 78% of the cases, 2 or more doses of the 4 milligram naloxone nasal spray were used in order to reverse the overdose. And as a matter of fact, in 30% of the cases, 3 or more doses were used. So we go from 2016 to 2021, we know, number one, we have a lot more fentanyl in the drug supply. Number 2, we're probably seeing at least some proportion of people who are not maybe primarily opioid users also experiencing opioid overdoses and are getting doses of naloxone. And in this same study, we also have data on, let's say, withdrawal symptoms based on the dosage. Unlike the Vishen study, in this study, we see the vast majority of people actually receive 2 doses or 8 milligrams of intranasal naloxone. Some received 1, some received 3, 4, even 5 doses, or upwards of 20 milligrams of intranasal naloxone. And even looking at this data, we don't necessarily see any dramatic increases, even going out to 3 doses. Headaches increases a bit, as does nasal dryness, but the rest of the numbers are pretty similar to each other. But I think the other interesting thing about this is when we look at the row of people reporting no adverse events, including withdrawal symptoms, it's only 2 people. So that's vastly different from the earlier obesity study. With the earlier obesity study, 2016, it was over half the sample. So what's going on here? We're still talking about the 4 milligram intranasal naloxone. We're still talking about primarily 1, 2, sometimes 3 doses of naloxone. So what actually is happening? And we have to indicate that, number one, again, we're dealing with a much more potent opioid. So ACE withdrawal or precipitated withdrawal someone might experience due to that might be tied into the potency of that opioid. Number two, I think it's also important to keep in mind that when we look at some of these withdrawal symptoms, we don't know that they're withdrawal symptoms unless we know for sure that the person is opioid dependent. Because a lot of these symptoms you're also going to see in people who experience opioid toxicity without withdrawal. And you also see this in people who experience hypoxia. And hypoxia means that the body is not getting a sufficient amount of oxygen. So, for example, with hypoxia, you're going to see confusion, you're going to see body weakness, nausea, vomiting, headaches, dizziness, etc. So when we talk about withdrawal symptoms, we have to, again, keep in mind, are these actually withdrawal symptoms? Or are they just symptoms of the opioid overdose itself? Are they symptoms of the hypoxia, or is it a combination? And that's especially important as we start to, again, consider more frequently the impacts of these opioids getting into the stimulant supply. All right, so next up, let's talk about opioids or naloxone and brain health, which I just alluded to, but we'll talk more about that. Let's see. There's a question that came up. How does it increase oxygen capacity? Does naloxone reverse the detrimental effects of fentanyl? Yes, that's exactly how naloxone works. So naloxone works to basically push the opioid, in this case, fentanyl, off of the opioid receptors. And by pushing the opioids off of the opioid receptors, that reverses the effects of the opioids, including the respiratory depression, the cessation of breathing, that sort of thing. Now, when the body doesn't experience or the body doesn't get enough oxygen, several things happen. Number one, you can get brain damage. I'll talk more about that in a few moments. But if the brain is not getting enough oxygen, that means other body tissues, other organs are also not getting enough oxygen. This includes the kidneys and other vital organs around the body system. The other thing to keep in mind is that some of the effects we see of opioids or the reversal of opioids, let's say someone experiences an overdose, you give them naloxone. It's not the naloxone itself, it's the fact that naloxone is reversing the effects of opioids. Opioids in and of themselves cause things like constipation, they impact your GI tract, so you get nausea and vomiting just with exposure to opioids, sometimes absent naloxone. And I think that's important to keep in mind because you can give someone naloxone who is not opioid dependent, is not using opioids at really high doses and nothing happens. Again, naloxone's only action is just to reverse the effects of the opioids. So a lot of the symptoms that we see in people following an overdose isn't because you gave them naloxone, it's because of what happened with the opioids and the fact that the naloxone is reversing some of that. And we can talk more about that if there are additional questions. All right, so we know that EMS response times can be delayed depending on where you live in the country, depending on what's going on, traffic, geography, et cetera, et cetera. And again, historically speaking, when we were dealing with other opioid overdoses, a lot of other opioids can take, several minutes, sometimes an hour or two even, to completely repress respirations. Fentanyl, as I mentioned earlier, acts much faster than that. The time from taking fentanyl to an overdose can happen in a few seconds to a few minutes. And once that overdose starts, which is basically signified by reduced in respiration, sometimes loss of consciousness, that means the person is experiencing hypoxia. And the time from hypoxia to brain damage can be as little as 4 minutes. That is obviously going to depend on the person's health, et cetera, et cetera. But generally speaking, it averages around 4 minutes. So the time period, again, that we have to reverse the overdose, save the person's life, but also try to maintain their brain health is significantly truncated. We don't have as much time to get to the person and get their breathing restored to normal in comparison to previous time periods with opioids. Now, again, if we look at hypoxia, there was a report that came out of the US Department of Health and Human Services where they found that over 75% of opioid overdose victims reported at least one post-overdose complication. So whereas these are individuals who experienced an opioid overdose, they survived their overdose, but because their brain, their body without a sufficient amount of oxygen for some period of time, they had these complications. And this included everything from ataxia, which is loss of full control of your body movements, catatonia, which is the state of immobility or stupor, impaired memory, mental disorientation, paraplegia, which is paralysis in the lower body, et cetera, et cetera. Furthermore, the department found that the risk for these overdose complications, this hypoxic injury, is higher for repeated episodes of hypoxia. So in other words, people who've experienced multiple overdoses, that effect on the brain and the body can be additive or even multiplicative, and for longer periods of hypoxia. In other words, the longer you go without oxygen, the more likely you are to have these outcomes, to have these complications. And again, I certainly understand that when we're dealing with people who are opioid dependent, there is a significant emphasis on trying to avoid, let's say, precipitated withdrawal and all the issues that come with that. It's an incredibly unpleasant experience at the very least. But again, I also want to keep everyone's attention on the fact that, yes, that's certainly an issue, which is one of the reasons why we have multiple formulations of naloxone. But again, we also have to, as far as I'm seeing, stop ignoring this other significant proportion of the population who's not opioid dependent, who will not experience withdrawal symptoms, but are going to fall into an overdose and may die of an overdose much easier, much faster, and with much lower doses of opioids because they have no dependency, no tolerance built up in their systems. So again, we have to keep in mind that, yes, we want to save the person's life, but we also want to make sure that we save the life, but we also maintain their brain health. Someone can go several more minutes without sufficient oxygen before they die. But again, at that 4-minute mark, you already have the danger of brain damage. Some other studies that have come out looking at various doses of naloxone. There was a study by Strauss and colleagues published in 2024 that compared different dosing strategies. So they compared, for example, administering 8 milligrams at the outset, in this case, 4 milligrams, versus administering a 4 milligram dose, waiting 2.5 minutes, administering a second 4 milligram dose, and if needed, waiting 2.5 minutes, administering a third. And what they found was that, number one, blood levels increase faster if you give 8 milligrams at the outset. You have a shorter period of hypoxia if you give a higher dose at the outset. And you also have a reduced incidence of cardiac arrest, which is how they define death. So you can save more lives by administering a higher dose at the outset. Furthermore, we have to keep in mind that we want to make sure that we give the person a sufficient amount of naloxone to restore their breathing to normal, again, as quickly as possible. And in some circumstances, in one study, for example, by Quinn, published in 2022, looking at nationwide toxicology data, they found that in 22.7% of fatal overdose cases, they did find some amount of naloxone. Now, we don't know if the naloxone dose was either insufficient to completely reverse the overdose, or maybe reverse the overdose temporarily and the person fell back into the overdose and there was not additional naloxone that could be administered. Maybe the dose was administered too late. The person was, let's say, too far gone in order to reverse their opioid overdose. Maybe a combination of both. We just don't know. And yes, some of the arguments or some of the discussions we've had around like what's too much naloxone versus too little naloxone. And again, the primary argument around or against giving higher doses of naloxone is related to the consequences of precipitated withdrawal, which again, I am certainly not trying to minimize. We know precipitated withdrawal is, again, an incredibly painful, or can be an incredibly painful, uncomfortable experience. But again, we're talking about precipitated withdrawal in only a very specific population. And again, that's ignoring other populations who could benefit from higher doses of naloxone. But also, from the data, we also know that giving someone too little naloxone, even people who are opioid dependent, increases the likelihood of hypoxia. And hypoxia can then lead to brain damage, and it can also increase the likelihood of death. All right, so there was another question. Is there a relationship between the concentration of naloxone in the body and amount necessary to reverse? That's a great question. Unfortunately, in the field, when we don't know the person's specifics around their health, their history, we don't know what opioid they took, or if we do know what opioid they took, we don't know the potency or how much. We may not know the route of administration, which all impacts how quickly the body metabolizes that opioid. It's impossible, let's say, to develop a personalized or customized dose of naloxone. Generally speaking, you give the person naloxone until their breathing returns to normal. The current FDA guidelines is give a dose, be that an intramuscular dose, a 4 milligram or an 8 milligram or a 3 milligram intranasal dose or what have you. Wait 2 to 3 minutes and then you give a second dose. In some parts of the country, there's also arguments to do rescue breathing. I'm certainly a fan of rescue breathing, but also keep in mind that not everyone who comes across someone who is experiencing an opioid overdose is going to feel comfortable doing rescue breathing or even can do rescue breathing for 2.5 minutes, even 3 minutes at a time. So in other words, there is a relationship with regards to how much naloxone should you give someone based on the opioids that they took. But in the field, we don't have that data in order to make that calculation, which is why doses come in just standard doses as opposed to something, let's say you might be able to titrate, which you could do. And a lot of people, let's say paramedics in the medical field, do that to great success. And some in the harm reduction community also have made that argument. But again, that's not necessarily the case for all of us. So we have to make sure that we have all the tools available for anyone who might respond to an opioid overdose. So I see another question. Would higher doses be best for those who experiment with illicit substances but don't have a dependence on opioids? That is certainly a great question. And there are some people around the country who do that. It's always been the policy of our organization to make all tools available, and then you select the tool that you feel is best for you, is best for your family, is best for your community. Certainly people who use stimulants would benefit from the higher dose. People who have previous use opioids, but maybe are in recovery, but are in danger of a relapse might be good for a higher dose. And then maybe keep the lower doses for people that you know are opioid dependent and you're concerned around precipitated withdrawal or what have you. All right, someone else asked, with multiple doses of naloxone having to be used in some overdose situations, how do you judge when to give more than one dose while also trying to prevent precipitated withdrawal? That's a great question. The thing to keep in mind about precipitated withdrawal is, number one, it is something that can happen with any dose of naloxone. That's why it is a warning on all formulations of naloxone, regardless of what that naloxone looks like. So you can give someone a very small amount of naloxone and they go into precipitated withdrawal, or you can give someone very large amounts of naloxone and they not go into precipitated withdrawal. There are so many individual difference variables that go into whether or not someone's going to experience precipitated withdrawal. But also keep in mind that as terrible as precipitated withdrawal is, it is temporary. It can be easily managed medically. If we think about the consequences of giving too little naloxone, again, you have brain damage and you could have death. So basically, you give naloxone, again, wait 2 to 3 minutes, hopefully do rescue breathing if you feel comfortable and you have that training. And within those 2 to 3 minutes, if the person's breathing has not returned to normal or EMS or paramedics have not arrived to take over, then you give a second dose. And you keep going with that process until either the person's breathing has returned to normal and or EMS has arrived. That's basically the standard protocol. So again, the main focus here is not necessarily preventing precipitated withdrawal, because that can happen. And I put question marks around, or quotation marks around preventing, not precipitated withdrawal. Around preventing precipitated withdrawal, because again, that could happen with any dose of naloxone. The main goal is to get the person breathing again as quickly as possible, because that is what's going to cause the long-term damage in the individual. Again, so why I think about it, we talked some of this, why higher doses, increase potency. We talked about brain damage, EMS response times. We've seen instances where multiple doses of the 4 milligram are being used. And again, we have to keep in mind the opiate naive and instances where people are experiencing fentanyl poisonings. So it's not to say that everyone should get 8 milligrams or a 2 milligram IV dose of naloxone or whatever the case may be. But it's just to keep in mind that different doses can be used with different populations depending on what population you work with. But also keep in mind that when we think about overdoses now, it's not just about those who use opioids. We have this whole other population of people making up 40, 50, sometimes more than that percent of the overdoses we're seeing who do not use opioids, who use stimulants and are not opioid dependent. All right, so just a few more slides and then we'll wrap up. So we're going to talk a little bit about the various medications. We've kind of talked about that already. So when we look at medications available around opioid use, opioid withdrawal, we have naloxone, which is the, let's say, the preferred medication in various formulations. There's vial, there's both 3 and 4 milligram. There's also the 8 milligram intranasal cloxaldo medication. We also have a newer medication that's now available, opiate, which is nalmefene. We'll talk about that in a moment. And then there's also naltrexone. So again, naloxone is an opioid antagonist. The oldest versions were administered via injection, either IV or intramuscular injection. There is a 0.4 milligram vial, which I showed earlier, which is generic, has a long history of use in the community, especially with harm reduction individuals. There's also a 2 milligram pre-filled syringe that's primarily used by people in the medical field. And again, we have various formulations of nasal naloxone. And nasal naloxone is especially beneficial for those of us who don't feel comfortable injecting people or might be working with various populations where we just don't feel comfortable having needles around or whatever the case may be. There's both the 3 milligram Revive, 4 milligram Narcan, and generics. Most people, when they think of naloxone, they think Narcan, but keep in mind, Narcan is a brand name. It's like Kleenex for tissue or Xerox when we need a photocopy. So the name itself has kind of taken over what it is. And then again, there is the 8 milligram intranasal naloxone medication, which was developed specifically to address fentanyl overdoses, and can be used primarily in populations that are opiate naive, let's say stimulant using populations. Couple other medications, and then I will finish up with the questions. There is naltrexone, which is available both in a tablet and in injectable formulations. Naltrexone is also an opioid antagonist. It's not used in opioid overdoses because the medication takes hours to peak in the system. This is instead used in people who, let's say, want to be protected against using opioids. So Vivitrol, for example, has been used in people who might have used opioids or might use opioids because it protects against an overdose, but it also takes the pleasure away from using opioids themselves. And then finally, we have nalmefene. And nalmefene, again, is also an opioid antagonist. It was available via injection for years. The nasal formulation of nalmefene was approved relatively recently. One of the things to keep in mind with regards to nalmefene is it has a significantly longer half-life than any of the formulations of naloxone, somewhere between 7 to 11 hours. So unlike when we look at, let's say, the 4 milligram versus the 8 milligram naloxone, intranasal naloxone, the 8 milligram has a half-life that's about 30 to 45 minutes longer than the 4 milligram. So not that much of a difference. But the nalmefene has a half-life. If we look at naloxone having a half-life of somewhere between 30 minutes to maybe 2.5 hours, depending on the formulation, this medication having a half-life upwards of 11 hours can result in significant prolonged precipitated withdrawal. If someone is on medication-assisted treatment or being treated for pain, that is going to cause complications or difficulty managing those outcomes. Plus, we've been using naloxone in the community for decades. We have not been using nalmefene in the community for nearly that long. And we don't really have any studies of using the nasal nalmefene in the community. And there have been several organizations that came out against using nalmefene, or at least not using nalmefene or looking at nalmefene as a replacement for naloxone because of that. So just to wrap up, and then I'll take any last questions. Again, I think we need to make sure we have expanded education and access to the medications used to reverse opioid overdoses. Again, we are a fan of all formulations in naloxone. You don't want to use the higher dose because you primarily work with people who are in active opioid use and have dependence and tolerance. That's great. But again, I also want to make sure that we keep the focus also on stimulant users and other people who use substances, indicated that they are not dependent on opioids because they are arguably in even greater danger of an overdose because their body is not used to metabolizing opioids. We also need to have a greater focus on brain health for all populations, opioid users or not. We're seeing more and more studies come out around the dangers and the implications of hypoxia and how important it is to get the person's breathing restored to normal as quickly as possible. And not to say that we should take the focus off of withdrawal. That certainly is not the thing, but also keep in mind that withdrawal is not going to be a consequence for a lot of people, and in some parts of the country, for most of the people who are now experiencing opioid overdoses. It just depends on where you live and the populations that you're working with. And with that, let's see some other questions that have popped up. All right, so let's see. I haven't heard that naloxone works on anything else other than opioids. Is there new research that shows that naloxone works on stimulants and other drugs? Yeah, no, naloxone as a medication only works to reverse the effects of opioids. It doesn't work to reverse the effects of stimulants. The reason why we're using or we're arguing for the availability of naloxone to stimulant users is because we're seeing an ever increasing proportion of opioid overdoses in people who primarily use stimulants, or people who maybe use a combination of opioids and stimulants. So in other words, people who use stimulants may not know that they should have naloxone because they think they're just using cocaine or they think they're just using methamphetamine. All right, so let's say this is interesting. When I think of the large amount of oxygen used to fuel the brain, I surmise that the stronger attraction of fentanyl may be driven by its love of oxygen. Is there any sense in these thoughts? Yeah, that is actually interesting. And I think the thing with fentanyl is because our brain has endogenous opioid receptors, because our bodies make its own opioids, I think it's not so much that fentanyl has a strong attraction to oxygen, but rather fentanyl has a strong attraction to these mu opioid receptors in the brain. And those opioid receptors, or those receptors, also control or have some effect on our breathing. So it's not so much that fentanyl is attracted to oxygen, they're both connected by the opioid receptors in the brain, if that makes sense. And then finally, because I see we are at time, I've heard that higher doses of naloxone can lead to vomiting upon withdrawal, which can lead to aspiration. Is this a concern? It is a concern in the sense that, again, any dose of naloxone can cause, let's say, precipitated withdrawal, but people experiencing opioid overdoses in and of itself, even absent naloxone, can experience vomiting. So that's one thing to keep in mind. And the data that I've seen looking at higher doses of naloxone didn't necessarily control for whether or not the person was opioid dependent. If you're not opioid dependent, you're not seeing withdrawal. You're just seeing the effects of the opioid overdose itself, which caused the vomiting. So aspiration is always going to be a concern, which is why when you come across someone who is experiencing an opioid overdose, you give them naloxone, you put them in the recovery position. So if they do vomit, the vomit should leave the mouth as opposed to them breathing it back in. But aspiration is always going to be a danger with opioid toxicity, opioid overdose, whether or not you give someone naloxone. And hopefully that answered all the questions. And I'm sorry, I went 2 minutes over time.
No, that's perfectly fine. I think we gave us a little bit of leeway since we started a little bit after time as well. So with that being said, does anyone have any other final questions before we conclude for today? I did go ahead and put the evaluation link in the chat. So please note that the eval will be open for a full week after today's presentation. And if you are wanting to earn CHES credits, there is a section where you have to enter in your number to do so. If we do not have any other questions, once again, I want to say thank you so much, Dr. McPhail, for your presentation. I feel like we got lots of feedback, lots of interaction, and I love it. This was great. So thank you all so much for joining us, and I hope you have a wonderful rest of your afternoon.
Thank you, everyone. Bye-bye.